you know, a stroke is not a stroke, it's not a stroke. It really depends on where you have the stroke, right? Every function that we do, whether it's something we consciously do or something that automatically happens, there's a particular part of the brain that controls that. So that's why you might know someone that has had a stroke that has maybe a motor issue where they can't, you know, maybe they're paralyzed on one side of the, or maybe they have difficulty speaking or getting thoughts out. There are types of strokes where people can completely understand what you're saying, they just can't get the words out to respond to you. But they understand. They just have a hard time responding to you. So that's why we see different kinds of problems in patients that have had strokes, because it really depends on where in the brain that they've had their stroke. The cerebral cortex is a part of the brain where thinking and voluntary movements start. Brain stem is a part of the brain where, you know, I said part of the things that we do, like breathing, we don't think about breathing, it just happens. The brain stem is where that is controlled. A good example of that is, you may remember there was an actor by the name of Christopher Reeves he played Superman. He had a C2 fracture, that's very high up on the spine, right at the brain stem. And he was dependent on a ventilator. It knocked out. He was not able to breathe on his own. So he had a trach. I don't know if you ever saw him after his injury. He had a trach. But the cool thing about Christopher Reeve is that he went around and became a spokesperson for people. He still had, you know, he still had his mind. He still, you know, he used his influence as an actor to go around and talk to people about traumatic brain injury. Same thing kind of happens with the stroke. If you get a stroke in the brain stem, you lose the ability to breathe and probably will die. But Christopher Reeve used his tragedy to help a lot of other people, so that was really a good thing. The basal ganglia is a part of the brain that coordinates messages between the various areas of the brain. The cerebellum has to do with balance and coordination. So I don't know if you've ever seen anybody that's had a stroke that just can't, you know, or lots of times they're sitting up in their chair, but they lilt to one side or the other. Their body says that that's straight. They can't help that. But you might notice if you know somebody that's had a stroke, and they have to be very careful about things like that. Some people can have a stroke where they don't even recognize a part of their body. It doesn't feel like it's attached. They don't know that it's even there. They don't see on that side. They don't feel on that side. And so they have to be very careful. If they have paralysis on one side, you know, they can injure themselves and not even realize that, you know, their arm is caught in the door or something. You have to be very careful. This is just a little picture, and I'm sorry, this is not a very good picture. It's not a very good place to have a PowerPoint because there's so much light in this room, so I apologize. But this is just a picture of where some of the functions are in the brain. We're going to talk a little bit about lobes here in a minute, but this has a picture of, you know, the different areas of the brain. There it is. It's a little bit better. Thank you. Where, you know, hearing comes in a particular spot, motor function, sensory, emotions. We have various lobes of the brain. The frontal lobe is responsible for problem solving and judgment. Frontal lobe is in the very front of your head, right here. Another very famous case. Way back in the day, in the 1800s, when they were building the railroad, there was a man by the name of Phineas T. Gage. His job was to, they didn't have heavy equipment back in those days, so they used dynamite to blast through the rocks and the mountains and stuff to lay the track. His job was to take a big iron staff, a big pole, it was about 4 or 5 foot long, and it was iron, to pack the dynamite. They drill a hole into a big boulder, they pack it full of gunpowder, and his job was to pack it down there, then put a fuse in there and light it, and blow up the rock in order to, move the rock to get the tracks down. One of these days, one day, Phineas was at his job, packed the powder, there was a spark, and there was an explosion. It sent the rod that he was using to pack the gunpowder, through his brain, through his skull. I've read the medical account of it. That everybody was amazed. He was, after the smoke cleared, they find old Phineas laying there. He's got this metal rod through his brain, and he's talking, and nobody can believe he's still alive. They take him to a doctor, and the doctor says, "Oh my gosh, now what?" But anyway, because of Phineas T. Gage, actually they did remove it, and he lived for many years after that. But the interesting thing, the reason that Phineas T. Gage is famous is it changed his personality. He was a God-fearing Christian man, hardworking. After his injury, he cussed like a sailor. He chased women. But the doctors, they did a lot of research on Phineas because they'd never seen anybody like this. They'd never seen an accident like that. So what they know is that the frontal lobe has to do with judgment. I don't know if have you ever seen the movie One Flew Over a Cuckoo's Nest? That's an old movie too, but one of the things they used to do back in the day with sight patients is do what they call a lobotomy. You ever heard of that? Yeah. Because they know it changes the way that you behave. They did it for poor sight people to try to get them to behave better or to be, less aggressive. But that's how they knew that part of the brain, that's what it controls. So I thought that was a very interesting story. The parietal lobe manages sensation, handwriting, body position. Parietal lobe is sort of here on the side of your head. Temporal lobes are just above your temples, right above your ear, right here. Memory and hearing are housed there. The occipital lobe is at the back of your head, and that's where the vision center is. Like I say, I just bring all this out to help you understand why, you put two people side by side that have had a stroke, and they're not going to be the same unless they've had a stroke in the exact same spot, and that's kind of a rarity. But anyway, how many of you are right-handed? The majority. Me too. Research shows 80 to 85% of us are right-handed. 10 to 12% of us are left-handed. And the rest are sort of ambidextrous people. The reason I say that, the reason I ask you that is the other unique thing about the brain is that when you have a stroke on the right side of your brain, it affects the left side of your body. It crosses the hemisphere. It's called. We have two hemispheres, a right and a left. So when you see somebody who has right-sided weakness, their right side is paralyzed, they've had a stroke on the left side of their brain. So only you left-handed people are really in your right mind. The rest of us are in the left side. Yeah, we use our left brain. The other interesting thing about the sides of the brain, certain functions. I was talking earlier about the lobes and stuff. Most of us are right-handed, so that means the left hemisphere is dominant usually in most of us if we're right-handed. That's not always the case, but some of us, use both hemispheres quite well. But most of us that are right-handed, we're left hemisphere dominant. That means we're very, we use scientific functioning, we use reasoning, we're good with numbers. Right-handed people, on the left side of the brain is where the spoken language is, the center is. The people who are right-brained are those creative kind of people. Do you know some people that just, they're artists, they're poets, they think differently, they really do. And those are the people who are right-brain dominant. Let's see, I'm sorry, this is kind of short. I have a hard time finding my area. Just some more stroke facts. Like I said, one of our goals in trying to get certified is to is to get education out there. Stroke is a very serious condition. It can change your life in the blink of an eye. I mean, if you can imagine what it'd be like, you know, to get up one morning and you do your routine and you go out to eat and you have a stroke, and you know, you may not be able to walk again, you may not be able to talk. I mean, it would just be devastating. It could be devastating. So one of our goals here is to try to educate people about a stroke, about signs and symptoms of a stroke, and what you can do about that. Depending on what sources that you look at, it's either the third or the fourth leading cause of death. I have seen some statistics that say it's the fourth, but still, it affects a lot of people. Nearly 800,000 strokes occur every year. 600,000 of those are a first-time stroke. 195 will be recurrent. A stroke happens every 40 seconds. So that's a lot, right? People die from a stroke every 4 minutes somewhere in the world. So it is a major thing. It's the leading cause of serious long-term disability. The majority of strokes happen in people older than 65. Statistics show that risk for stroke doubles each decade after 55. Well, that's not a very comforting thought, is it? No. As we look at the calendar, that's not. But it's a fact of life, ladies. And we'll talk a little bit about what we can do to prevent that. Does anyone here know any risk factors for stroke? High blood pressure. Exactly. I'm sorry? Diabetes. Exactly. Smoking. That's certainly one that we can control. You know, we can't change our age. We can't change our DNA. We can't change, you know, our family history, who we're related to. Sometimes that, you know, it's a genetic thing. You can't control those things. But there are things that we can control. You know, if we have high blood pressure, we can make sure that we keep it under control. Take our medicine, see our doctor, do the things that we have to do. If we smoke, we need to stop. I'm not here to preach, but anyway. Strokes can and do happen at any age. I work here at the hospital. My background is ICU. In the last couple of months, we've had 3 patients in the ICU with stroke, younger than 60. One of them was 55. 2 of them were in their late 40s. Wow. 55-year-old came in. By the time he got to the emergency room, he came in with right-sided weakness. His arm and his leg, weakness on one side. We gave him clot buster, which we're going to talk a little bit about that. He left the hospital in 48 hours with no deficit. Wow. That's the kind of thing that you like to see. The 2 other cases, the 48-year-old had a brainstem stroke. He died. 48 years old. 48 years old. The other patient we actually transferred. She had this was a female, had a history of having had a prior stroke, had a history of hypertension. She'd had a stroke about 9 years before, so she had her first stroke before age 40. Had some weakness, but, you know, was manageable. I mean, she was, you know, managing at home. Stopped taking her blood pressure medicine because she was feeling better. Had another stroke, a big stroke. So, I don't tell you this to, well, I guess I am telling you this to scare you. You know, this is an important thing. Like I said, we can't prevent all the strokes, but we can do what we can to prevent, you know, to manage the risk factors that we know about. And that's what the message that I'm trying to get across to you. Stroke is a brain attack. Just like a heart attack, you know, we need to act just as urgently. Somebody starts having chest pain, we know what to do. We know to call 911. And it's easy if, you know, you look over at a family member or somebody that you're with and they have entire weakness on one side, that's pretty easy. It's easy to recognize. Unfortunately, it's not all, you know, their symptoms are not always that, sometimes they're more subtle than that. Sometimes it's just, one patient I know came in, had numbness in his chin. It's kind of a bizarre complaint, but that was his complaint, numbness in his chin. Came to the emergency room. Blood pressure was very high, so we did a CT scan, and he was having a stroke. So that was kind of a bizarre presentation, but you never know. You know, err to the side of caution. Why do we call it brain attack? Because it is a true medical emergency. You lose 2 million brain cells every minute during a stroke. I don't know about you. I don't have many to lose. I need all the brain cells I have. I don't have any to spare. So you need to get help fast and call 911 stat. But I want you to know some of the signs and symptoms of a stroke. Most strokes, there's only two kinds of strokes. We either have an ischemic stroke or we have a hemorrhagic stroke. Ischemic, there are two types of ischemic. It's either an embolic or a thrombotic. That's a medical thing. You guys don't really need to know that. That means either a clot has traveled to your brain or you have a brain bleed. So when someone comes into the emergency room, what it means for us here at the hospital, when somebody comes to the emergency room, the first thing that we want to know is, which is it? We take you to CAT scan, we scan your head. If it's a brain bleed, then there's really nothing that we can do here. We probably will ship you. Depending on the size of it, it may be something that you watch. One of the things that can happen, you know, your head, the cranium, the skull is a non-movable object, right? It's a closed box. It's a bone. Your brain is inside here. So there's not much room for swelling. If you start having swelling or if you have a bleed, it puts pressure. And what happens, what you see in a brain bleed is that, you know, you start adding extra capacity to this little closed box. It starts putting pressure on everything else. So sometimes you have to go in and evacuate that. Sometimes it's enough pressure to make it stop bleeding. It'll sort of stop bleeding on its own just because of the closed box theory. So if it's small enough, that might be something that it would resolve on its own just because the pressure might stop. If it is an ischemic stroke, we can treat those. That's the good thing about it. 85% of strokes are ischemic, and ischemic, if you come to the hospital soon enough, can be treated with clot buster drug. I told you about the 55-year-old man that walked out here with no deficit. We can give something called TPA. That's the fancy medical word for it, but it's a clot dissolving medication. If you meet criteria, and there is very strict criteria that you have to meet before you can take something like this. It has to be within a certain time frame, 3 hours or less from the time of onset. You can't recently have had a major injury or major trauma like surgery. If you've recently had surgery and we give you clot buster, you don't clot. The blood's not going to clot, and it's going to cause you to bleed from your surgical side. So if you've had fallen recently and hurt your head, that would eliminate you. If we can't get your blood pressure under control with medication, then that would be a contraindication as well. Usually they do not give it to people over 75 either. But I told you we were working on our stroke designation. It kind of depends on, like I say, there's very strict criteria. Yes, ma'am.
Why don't they give it to you after 75?
Because you're more likely to have a bleed.
So what do they do? Just let you...
Well, clot buster drug, I don't know.
I mean, I'm not far from there. The reason I'm asking.
Right. If we give you something like clot buster drug, it dissolves clots in the body. That's what a clot buster will do. Some of you may take meds like Coumadin or Plavix. Those are blood thinners. But this is like an era irreversible. It's going to dissolve any clot in the body, and so if there's an avenue for a bleed, it's going to bleed. And I've seen, and sometimes that is a risk, even if you're not 75. I mean, sometimes it does happen. But I guess when you consider what's the alternative, and that's really the way it's determined. The physician determines it. I told you we were working on stroke designation. One of the things that we have here, I don't know if any of you know Dr. Fail. He is a wonderful neurologist that we have here on staff. He heads up our stroke program here. The other thing that we have is down in the emergency room, we have a robot. The nurses have called him, they named him Dexter. Really, it's just kind of a little cart that has a laptop on it, and it has a camera on it, and the people at Memorial Hermann in Houston, which they have a stroke hospital there. It's not just a center; it's an entire hospital specifically for stroke patients. They have world-renowned, well-known neurologists and neurosurgeons on staff there that are on call 24 hours a day. And so if we have somebody come into our emergency room, if Dr. Fail's not available, or if it's 2 o'clock in the morning, we can call the neurologist at Memorial Hermann who's on call, and he can actually do an interview with the patient with this camera. By using a laptop and a camera, he can actually, he will zoom up, it'll flash on the screen, he'll focus on you, and he'll say, okay, smile, raise your hands. He'll do his assessment. He can look at the CT scans through the internet that we do here. He can upload the CAT scan, and he'll say, yes, let's give them TPA, no, let's don't, or ship them to Hermann. I mean, he's the one that determines what the treatment is. So that's a very nice thing for us to have here. Like I say, if we see a bleed here, we don't have a neurosurgeon, so we would pretty much have to ship that.
Can you repeat why you don't do this for anybody over 75?
Because of the risk of bleed. There is a criteria sheet that when someone comes into the emergency room and it's determined that they're having a stroke and it's not a hemorrhagic stroke, and they may possibly be a candidate for TPA for clotbuster drug, then the nurse has to go down this checklist to see if they meet criteria, because it's a very dangerous drug. It can save lives. I've seen it work very well. I've seen it also cause bleeds. So it's a very dangerous drug, and if you're high risk for bleed, if, for example, one of the other exclusionary criteria is we can't get your blood pressure below 185 over 110 with drugs. If we give you medicine and your blood pressure is still higher than that, we can't give you TPA. But the reason, the age exclusionary thing is because you're at more risk to have a bleed where you don't want it, either in your head or, like I say, if you've fallen, if you've had surgery, there's other, risk for bleed, because they bleed. If you give somebody TPA, you have an IV in their arm, it bleeds around their IV. I mean, they just start oozing because their blood doesn't clot anymore.
So what do you do?
How long does that effect last?
It clears very quickly, usually about 24 hours. Depending on the dose that we give, there's a formula that you give the patient. It's based on weight, so everybody kind of gets a different dose depending on how big you are. But it's they go to the ICU because it is a very dangerous thing. Even just doing a lab draw, they're not gonna clot. You have to be very careful what invasive procedures you do. You make sure you have all your IVs in. You try not to stick anybody, like for lab draw, because they don't stop, even with a lab draw for 24 hours. Yes, ma'am?
What about the people who are having a stroke but it doesn't show on the CT scan?
That happens very frequently. It's just one of those things. Even bleeds, depending on how quickly you seek medical attention, sometimes it just won't show up. If there's not enough blood to make contrast, when you look at the film, it's very easy to miss. But let me talk to you about some of the warning signs. This is really one of the main things that I wanted to get across to you. Whether things have been missed in the past, I mean, who knows? But I want you ladies to be prepared. So if you see this, or if someone, either yourself or someone that you're with, these are some of the signs. Like I say, nothing's ever written in stone. I told you about the guy that had numbness in his chin. That was a very strange presentation. I think I would preface this by saying, anything out of the ordinary, err to the side of caution. Call your doctor. If you have a primary care physician, call him and say, is this something I should go to the emergency room about? Sudden onset of numbness or weakness in the arm, face, leg, especially if it's just on one side. Sudden confusion, trouble speaking or understanding. Trouble seeing, all of a sudden blurred vision, double vision. Trouble walking, or balance problems. You feel like you're under the influence. Sudden severe headache or unknown cause. Those are all very classic. I want to pass out some cards to you. FAST is a national thing by the American Stroke Association that it's a little mnemonic to sort of remind you of things that you can do if you think someone's having a stroke. Like I say, it's obvious when somebody has weakness completely on one side, but lots of times it'll just be one small area or just a little bit lightheadedness or dizziness, and somebody will say, I'm just tired. Maybe I should just go take a nap. We're very good at denying things and wishing things away and making excuses for the symptoms that we have. But this is a little thing to remember. It's called FAST. Face, arm, speech, time. So if you think someone might be having a stroke, you ask them to smile. See if their smile is equal on both sides. Unless they've just been to the dentist, they should be able to. You get them to smile. You get them to wrinkle their nose, lift their eyebrows, stick their tongue out. That's exactly right. Frown. It should. Everybody's face looks different. Everybody's smile, everybody's mouth looks different, but it should be the same on both sides. That's the key. Yes, ma'am.
Is Bell's palsy considered a stroke?
No, Bell's palsy is a temporary thing. It does look like a stroke. It is actually an infection around a nerve in your head. So it is something that will go away, but it's exactly like a stroke. But the thing about Bell's palsy is it's only your face. You won't have any numbness or weakness down your arm or your leg. It'll just be your face. It'll just be like having gone to the dentist where one side of your face doesn't work. Your smile won't go up. You can't
close your eyes.
Yeah. It's just but that has to do with I think it's the trigeminal nerve. I forgot, but anyway, it's an infection around the nerve. Did someone else have a question? No. Anyway, so you get someone to. You assess their facial features. You ask them to hold out their arms, close their eyes, hold out their arms. Someone who's having a stroke, one arm may go down. They don't realize it. They're holding it out straight, but one arm may drift down, and that's a classic sign as well. Ask them to say a very familiar phrase, something that they should know, something like, well, Peter Piper's probably not a good one. That's hard on a good day. But something very familiar that they should know. Something like, it's hard to teach an old dog new tricks. And then ask them what that means. What does that mean? Sometimes they can say things, but they can't really it's a comprehension thing. So if they don't understand what that means, that could also be a sign. And remember, time is of the essence. If someone's having a stroke, call 911. Risk factors we kind of already talked about. If you had here's TIA. We kind of talked about TIA. TIA, anytime you have a TIA, stands for Transient Ischemic Attack. If you've had a TIA, that is a warning sign. That is God saying, Mary, Mary, pay attention. You are not, getting your blood pressure under control. That is a warning sign. Don't ever let it go unheeded. This is lots of people that have TIAs, will have weakness or numbness, and then it all goes away and everything's great and they think they're out of the woods. But people that have TIAs are more likely to have a full-blown stroke within 30 days. So always, always, always pay attention to that. Don't let that go as, just write it off as nothing, because that is a warning sign. If you've had a previous stroke, we've already talked about, you're more likely to have another one. Cholesterol, we've mentioned, blood pressure, heart disease, atrial fibrillation. I don't know if anybody in here has AFib. That's a very common thing. You probably are on blood thinner. One of the things that makes AFib so dangerous is, your heart's not in good rhythm, and there's a possibility of it having clots in the atria, in the right atrium, which is the top of your heart. And the place that it goes is either to your lung or to your brain because of where the heart is.
That's why you take so much blood thinner.
That's why you take blood thinner, yes ma'am. That's why you do that. But it also increases your risk of having an embolic stroke because of the chance of getting a clot. So, coronary artery disease is also a risk factor. Prevention, we've already talked about. Take your blood pressure medicine, stop smoking, control alcohol use. I think they say drink in moderation if you have to drink. What is moderation? For women, they say 1 drink a day, whether that's a beer, glass of wine, or mixed drink, 1 a day. Men, it's usually 2. Monitor your cholesterol, take your medicines, manage your weight, exercise. And